Welcome to another episode from the Veterinary Medicine Digest. Today, we're diving deep into the world of canine epilepsy, specifically focusing on a long-standing treatment, phenobarbital. Managing epilepsy in our beloved dogs is often complex, with only a limited number of effective drugs available, and undesirable adverse effects are not uncommon. Traditionally, phenobarbital has been a cornerstone in this management since its introduction into human medicine in 1912. It's a first-line treatment for canine epilepsy, appreciated for its efficacy, affordability, and pharmacokinetic properties that allow for convenient dosing every 12 to 24 hours. However, phenobarbital does come with challenges. It has a relatively narrow therapeutic index, meaning the line between an effective dose and a dose causing adverse effects can be quite fine. Its primary elimination pathway is hepatic or liver-related, and it's known as an autoinducer, meaning it can speed up its own metabolism, leading to a progressive reduction in its elimination half-life with chronic use. This significant variability between individual dogs necessitates careful therapeutic drug monitoring to ensure optimal dosing, maximizing efficacy while minimizing risks of toxicity. Our exploration today will draw on several studies that shed light on phenobarbital's effectiveness, its adverse effects, and ongoing efforts to optimize its use. Let's begin by discussing phenobarbital's efficacy in controlling seizures. One study found that dogs treated with phenobarbital experienced significantly fewer seizures after treatment, with 5 out of 6 dogs classified as true responders, meaning they had a 50% or greater reduction in monthly seizures. In fact, when compared to dogs treated with levetiracetam, phenobarbital-treated dogs had significantly fewer epileptic seizures per month after starting treatment. This overall positive impact on seizure control is a key reason for its widespread use. For instance, one study found that 86% of dogs on phenobarbital monotherapy showed an improvement in seizure frequency, with 23% becoming seizure-free. Phenobarbital has also shown a greater improvement in controlling cluster seizures compared to zonisamide, with 80% of dogs in the phenobarbital group experiencing a decrease in the number of seizures during these episodes. In cases of phenobarbital-responsive sialadenosis, an unusual form of limbic epilepsy, initial phenobarbital treatment has been shown to completely resolve clinical symptoms such as nausea and vomiting within 48 hours. Now, for a more somber note, the adverse effects. These are not uncommon with phenobarbital. Common adverse effects include polyphagia, polydipsia, polyuria, sedation, and ataxia. One study reported that 77% of dogs on phenobarbital monotherapy experienced one or more adverse effects, which was a higher rate than those on levetiracetam or zonisamide. The mean number of reported adverse effects per dog was also significantly greater for phenobarbital. Specifically, 54% of owners reported increased appetite, 46% reported increased thirst, 37% reported sedation, and 29% reported increased urination. Restlessness, weight gain, and decreased activity were also common. Beyond these more common issues, more serious, though rare, adverse effects can occur, such as superficial necrolytic dermatitis, Pancytopenia, hepatotoxicity, and acute pancreatitis. Let's delve into the liver effects, which are particularly complex. Phenobarbital is a hepatic microsomal enzyme inducer, leading to proliferation of the smooth endoplasmic reticulum in liver cells, increased liver weight, and accelerated metabolism of drugs. This enzyme induction can cause increases in serum liver enzyme activities, specifically alkaline phosphatase, alanine transaminase, and gamma-glutamyl transferase, even without actual liver damage or biliary stasis. In a study that observed dogs for 29 weeks, alkaline phosphatase was significantly increased up to 10-fold above baseline in most dogs, and alanine transaminase also increased. Gamma-glutamyl transferase had a transient increase. However, careful examination of liver tissue showed no morphological evidence of parenchymal damage, with the observed ground glass appearance of liver cells attributed to this smooth endoplasmic reticulum proliferation rather than intrinsic toxicity. Liver enlargement, observed radiographically, was also linked to this enzyme induction. Interestingly, other liver function tests, such as aspartate transaminase, fasted bile acids, and total bilirubin, were not affected by this enzyme-inducing effect, making them more reliable indicators of actual liver disease in dogs treated with phenobarbital. Moving to even rarer and more severe adverse reactions, we have Pseudolymphoma and Pancytopenia. Pseudolymphoma is a hypersensitivity reaction to antiepileptic drugs, recognized in humans and reported in a cat, and now suspected in a dog. This condition mimics lymphoma, presenting with symptoms like lethargy, dazed mentation, pyrexia, generalized lymphadenopathy, hepatomegaly, and splenomegaly. In one case, a 2.5-year-old shepherd mix on phenobarbital at a therapeutic dose developed these signs. Cytology of lymph nodes showed reactive cells, and liver and spleen biopsies revealed inflammation, but not neoplasia. Critically, all clinical signs resolved within 24 hours to a week after phenobarbital was discontinued, with the dog even experiencing its longest seizure-free interval after withdrawal. This highlights the importance of considering pseudolymphoma as a differential diagnosis for lymphoma-like signs in dogs on phenobarbital, as early recognition and drug discontinuation can lead to a full recovery. Pancytopenia, a deficiency of all types of blood cells, is another serious idiosyncratic reaction. In one instance, a 4-year-old St. Bernard Mastiff crossbred dog receiving phenobarbital for seizures developed lethargy, anorexia, and mild pyrexia, which were later attributed to severe neutropenia, moderate thrombocytopenia, and mild anemia. Blood values, including neutrophils and platelets, significantly decreased. Like pseudolymphoma, this is a rare and unpredictable reaction. Diagnosis relies heavily on a positive response to discontinuing phenobarbital, as clinical signs are vague. In this case, upon discontinuing phenobarbital and initiating zonisamide, the dog's clinical signs improved and blood values returned to normal within 3 weeks. Prompt discontinuation of the drug and supportive care are paramount for survival and recovery. Optimizing phenobarbital treatment is an ongoing area of research. A population pharmacokinetic model, which considers how drugs move through a group of individuals, has been developed to assist in phenobarbital dose optimization in dogs. This model, based on real therapeutic drug monitoring data, showed that a one-compartment model with an auto-inductive clearance process best described how phenobarbital concentrations change over time. This means that phenobarbital increases its own metabolism, causing a progressive decline in plasma concentrations after an initial rise, eventually stabilizing at lower levels than seen in the first few days of treatment. Both body weight and age were identified as significant factors influencing how quickly phenobarbital is cleared from a dog system, with sex not playing a significant role. Specifically, dogs weighing less than 10 kilograms, especially those under 1 year of age, may require higher doses to reach therapeutic levels, while older dogs might need lower doses due to age-related decline in renal function, as about 25% of phenobarbital is eliminated renally. These findings led to proposed individualized dosing regimens, including recommendations for loading doses to achieve therapeutic concentrations more rapidly, which could be particularly beneficial in managing acute epileptic conditions. This model-informed precision dosing offers a framework for tailoring phenobarbital therapy to each patient, potentially improving both efficacy and safety. Finally, let's consider caregiver perceptions of phenobarbital. Despite the higher incidence and number of adverse effects associated with phenobarbital compared to newer drugs, caregivers often report a favorable outcome overall. One study found a significant improvement in the mean quality of life score for dogs on phenobarbital monotherapy, with no difference in quality of life scores between phenobarbital, levetiracetam, or zonisamide groups. This suggests that while adverse effects are more common with phenobarbital, they may not always lead to drug withdrawal or severely impact a dog's quality of life, especially if seizure control is perceived as improving. The most common reason for treatment withdrawal across all drug groups, including phenobarbital, was inadequate seizure control, not intolerable adverse effects. This underlines that seizure frequency remains a primary concern for caregivers when assessing the success of an epilepsy management plan. In conclusion, phenobarbital remains a widely used and effective antiepileptic drug for dogs with idiopathic epilepsy, offering significant benefits in seizure control. However, veterinarians and owners must be vigilant about its diverse range of adverse effects, from common issues like sedation and increased appetite to rare but serious reactions such as pseudolymphoma and pancytopenia. Advances in pharmacometric modeling are enabling more personalized dosing strategies, considering factors like age and body weight to optimize outcomes and minimize toxicity. Despite its challenges, a clear understanding of phenobarbital's profile allows for informed decisions, ensuring the best possible quality of life for dogs living with epilepsy. Thank you for listening. The titles for the reference papers are in the video description. Signing off from the Vet Med Digest, where we keep minds inspired, hearts light, and tails wagging.